Hi, I'm Dr. Mike Bowman, one of the physicians here at Powell Valley Healthcare. And if you remember, we did an article in the Powell Tribune several months ago talking about screening and the different diseases that you screen for or conditions that you screen for. And we were going to do a series of video presentations on the different diseases that you screen for. So this is the first in that series. And so the first one I thought we would go over is colon cancer screening, or they also call it colorectal cancer. But basically it's your large intestine is your colon, and you're screening for cancer in the colon. So colon cancer is one of the leading causes of illness and death in the United States still. It's the third leading cancer in men in the United States and the second leading cancer in women. And so your lifetime risk of developing colon cancer is about 4%. So 4 out of 100 people throughout their lifetime in the United States will get colon cancer. But ever since I was a resident, which is getting to be a long time ago now, 25, 30 years ago, they started doing endoscopy for colon cancer screening then. And that enables a person to remove a precancerous polyp before it turns into cancer. And so since that time, about in the 1980s, something like that, the incidence of colon cancer has been going down about 2% per year. So screening has really made a difference in regards to colon cancer illness and death. So this video is going to be talking about colon cancer screening. Jim Cannon's here. He's the director of public relations and marketing for the hospital, and so he may ask me questions, and then we may change locations and show you what the endoscopy suite looks like and what a colonoscopy is like when we talk about colonoscopy. So the first thing, if you remember in the article that I wrote in the paper, there's different diseases to screen for and other ones that you wouldn't want to screen for. And so what makes a disease a good one to screen for is if the disease is pretty prevalent in the community, in the overall community, in the population, and then if there's a long preclinical phase, so a long phase of when you have the disease or pre-disease where you can make an intervention and then make a difference in the outcome of the disease. And so colon cancer is one that fits for. And like I said, when they started screening for colon cancer, probably in the 1980s and a little bit later, the incidence of colon cancer has been decreasing. So that's great. So I was talking earlier about polyps in your colon. So polyps are precancerous lesions. And so if you can remove a polyp, which looks kind of like a little mushroom inside your colon, it's a growth in your colon or large intestine. And so if you can remove those before they undergo dysplastic change or start turning into a cancer, then you basically cure cancer if you remove the polyps beforehand. So what are your chances of getting a polyp or a precancerous lesion in your colon? Well, for men, it's about 30% of men throughout their lifetime will get a colon polyp, and about 20% of women. And like we said, not all those turn into colon cancers, but 4 out of 100 people will eventually get colon cancer. And about 53,000 people a year in the United States die from it. So if you can remove those polyps, which are much more common, before they turn into cancers, then you kind of cure the cancer. And it's funny, there's been a lot of polyps that I've removed that you can actually find cancer cells at the end of the polyp where it's just turning into colon cancer. And so that makes you feel really good whenever you can remove one of those for someone.
So Dr. Bowman, you're talking about screening and how important it is for preventing colon cancer. So what age does a person start this?
Well, that's a good question. Most of the organizations all say start at age 50, but that's in a normal risk individual. So things that make you higher risk for colon cancer would be if you have what they call a first degree relative that has colon cancer or that had colon cancer. So that would be like a mom or a dad or a brother or sister is a first degree relative. And so typically you want to start screening 10 years before the age your first degree relative was when they had colon cancer. So say you had your father that had colon cancer when he was 53, so you'd want to start screening at age 43. And then there's a bunch of different recommendations on frequency of screening and stuff, but so for normal risk individuals, you start at age 50 or 10 years before your first degree relative had colon cancer. But then also there's other conditions that increase your risk for colon cancer. So if you have a family history of different diseases that make you have polyps, like familial polyposis syndrome, and there's some other ones, or if you have inflammatory bowel disease, that's ulcerative colitis and Crohn's, those would all be higher risk diseases that would make you at higher risk for developing colon cancer, and so you would start screening earlier. So it kind of depends, but for the general population, it's age 50.
So how long does a person do these screenings?
Well, you keep doing it. Everyone agrees that you do it at least till age 75. It used to be 80, but they just recently changed it to 75. But then another thing that seems to be what everybody agrees upon, if people are going to live another 10 years, then you would continue screening until you think that they have a life expectancy of 10 years or less. So if someone's really healthy and they're 82 and don't have diabetes, heart disease, or something else that you expect them to die from in the next 10 years, then you'd probably keep doing screening or at least talk to the patient about it. But typically it's age 50 to 75.
So, Dr. Bowman, are there other ways that you can screen for colon cancer aside from just a colonoscopy?
Yeah, there are. Most of the medical societies, the gastroenterology specialty group, the American College of Physicians, the American Academy of Family Physicians, the United States Preventative Services Task Force, almost everybody agrees that colonoscopy is the best way to screen because you get it all done at once. But there are other ways, and what I mean by getting it done all at once is that you can find a polyp and take it out and you're done. So other ways to screen, though, that are still pretty good, they still detect disease, pretty good. The sensitivity is maybe a little bit less where you don't find cancers as easily, but other ways are 3 of them are stool-based tests. So if you remember, one of the options for screening used to be every year you'd come in for your physical and the doctor would do a rectal exam and get stool on his finger and put it on a card and look for occult blood on that card. And so testing your stool for occult blood is still a way to screen, but that method missed too many, and so now they say that you should do 3 consecutive stools and use a different type of reagent than the one the doctor uses in the office. So that's still an acceptable method, but you have to do that every year in order to catch enough of the colon cancer, of the incidences of colon cancer. So yeah, if you do fecal occult blood tests, you have to do 3 stools in a row, normally from home, bring them into your doctor. They use a special reagent that looks for blood that you can't see with your eye, but you can see with the chemical. But if that's positive, then you still have to go do the colonoscopy in order to find out what it is in your colon that's bleeding. And so that's one stool-based test. Another one is called FIT testing, and so it's an immunochemical test on stool that you send in, and it tests for hemoglobin in your stool. So it's a little bit different, but that also is once a year. It's pretty cheap. It's like $50, but you have to do it every year, and then if it's positive, once again, you got to go do a colonoscopy to see what it was that was bleeding. Was it a polyp that was bleeding? Was it a diverticulum that was bleeding? Something that's not even precancerous, or was it a cancer? And then another stool-based test that is kind of becoming popular, you've probably seen commercials on TV for it, is called Cologuard. And so it uses, it's a test where you actually send in your whole bowel movement instead of just a smear of your stool on a card. You have to ship the whole bowel movement to them, and they look for mutations and methylation of DNA on that, as well as occult blood, and it's about 92% sensitive. So they think colonoscopy might be 98%. So out of 100 people who have the disease, 98 test positive, and the Cologuard's about 92% sensitive. But then, once again, if you have a positive Cologuard test, then you still have to go have a colonoscopy in order to see what it was that made the test positive. So those Cologuards, I've never ordered one for anyone, but it looks like they're about $500. The fecal occult blood test is pretty cheap. I think it's probably $20-25, and then the FIT testing is $50. So the FIT testing and the fecal occult blood are every year. Cologuard is every 5 years. But if any of them are positive, then you still got to go have a colonoscopy. And so with a colonoscopy, it's about $3,000 when you add everything together. And it requires a bowel prep. Those other stool-based tests don't require bowel preps. And then it requires sedation. You probably want to be sedated when you have it done. Although I've had some people that don't. And so anyway, the whole test costs about $3,000. But the good thing about colonoscopy, most people agree that if you have a negative colonoscopy for screening, remember screening's looking for disease without symptoms. If you have a negative colonoscopy, then you get to wait 10 years and you don't have to do any of the other screening in between times. So anyway, so there's colonoscopy. That's kind of the gold standard that everybody agrees is the best way to screen. But you can also do stool-based tests, those three that we talked about. But if they're positive, you got to do a colonoscopy. And then some people ask me about virtual colonoscopy. So what that is, that was going to be all the rage a few years ago, but it turned out to not be as good as they thought it was going to be. It still requires a bowel prep, and then you have to have something inserted into your rectum to put air in your colon, and then they do a fancy CAT scan. So that's what a virtual colonoscopy is. But once again, if it's positive, you got to go have a colonoscopy done to remove whatever it is, or biopsy whatever it is that looks abnormal on the virtual colonoscopy. And then there's another option called capsule endoscopy, and so this was another thing that people were kind of hoping would be an alternative that was viable to colonoscopy. But that's where you swallow this pill, a capsule that has little bitty cameras on it, and it takes pictures of the inside of your colon as it goes through your bowel. And so that sounds great. Again, if it's positive, you still have to have a colonoscopy. But they're kind of expensive. They're not approved by the FDA because they weren't as good as they thought they were going to be for screening. And then he still requires a bowel prep to have it done. And I think a lot of insurance companies kind of have a hard time paying for that. About the only utility for capsule endoscopy is if you have an incomplete colonoscopy, or if you have someone that needs a colonoscopy and they can't undergo the procedure because of a comorbidity where they can't be sedated or something. So those are the 5 main ways: colonoscopy, the 3 stool tests, virtual colonoscopy, and capsule endoscopy. But pretty much everybody agrees that colonoscopy is the main way to go, especially since you got to do a colonoscopy anyway if you find something with the other tests. So basically, that's the age you start or the ages that you screen, and then the different ways that you can screen. And remember, screening is looking for disease without symptoms. So the screening thing doesn't apply to someone who has symptoms of colon cancer. So if you have blood in your stool, or if you have unexplained iron deficiency anemia, or if you have a change in your bowel habits, like all of a sudden getting bad constipation or diarrhea, or having unexplained abdominal pain, those things could all mean you could have colon cancer, and so that wouldn't be screening. You'd still need to probably do a colonoscopy or some other investigation, but what we're talking about is screening where you don't have any symptoms. So that's the different ways to screen and the different ages that you of people that you screen. And so since colonoscopy is kind of the main way to do it, Jim and I will go over to the endoscopy suite and we'll kind of explain the procedure of colonoscopy, show you the equipment and where you would be, and explain the complications and stuff, and then yeah, that way you'll know what to expect. All right, so here we are in the hospital, and so you'll do your bowel prep the day before you have your colonoscopy done, and then you'll check in at the front desk at the hospital, and then you come down here, and then here's where surgery is. So this is where we do the endoscopy. So we're going to show you where the endoscopy suite is. So when you come, you'll be, like I said, you'll check in, your family members can stop here, and then the nurse will bring you back here. And so there's these pre-op rooms where the nurse will check in, and then they'll put in an IV, and oftentimes the anesthesia provider will come and talk to you about the sedation. And then when you get all ready, then they'll move you back here to the endoscopy suite. So it's through these doors. And you'll have to have someone drive you home after your colonoscopy, because you'll be sedated and you're not supposed to do anything dangerous the rest of the day, including driving. So the endoscopy suite is back this way. And so there's different kind of doctors that do endoscopy, both upper and lower endoscopy or colonoscopy. And so generally it's gastroenterologists, which we don't have any in PAL. There's some in Billings, but none of them come to the basin and do clinics or anything. And then general surgeons do endoscopy, and then family practice people that are trained in endoscopy do it. And so in town, there's 3 of us that do endoscopy: Dr. Reeb, our general surgeon, and then Dr. Christensen and myself, who are family medicine, who are trained in endoscopy. So this is the endoscopy suite, and so the machine that the scope's hooked up to is there, and then there's a TV screen over here that will normally go right here. And the person getting the colonoscopy will be here, and then there'll be a nurse here, and normally an anesthesia provider here, and then whoever's doing the endoscopy, me, Christensen, or Reed, will be standing there, and then there'll be an assistant helping us too. So that's who all's in the room. So basically they bring you back here. We get all these consent forms, it requires a bunch of paperwork to do, but we'll get the consents all done, and then the anesthesia guy will start giving you the medicine that makes you sleepy. And so I'll show you what the scopes look like. So colonoscopes are kind of big because your colon's large. And so basically this is what they look like. And so this end is the part you insert, and it's got fiber optic cables in it, and a light shows, and then the picture shows up on the TV screen that'll be over here. And then if you can look, the way that we direct the ends of the scope is you can make it go up, down, and right and left, and then there's these buttons that'll be on here that can blow air into your colon, because if you think of it, your colon's like a flat balloon without any stool in there after you've taken the bowel prep, and so we have to put air in there to blow it up. And then we can take pictures, we can suck stuff out. If there's any liquid left over from the bowel prep, we can suck it out. We can squirt water in there, and then also you can run the biopsy forceps down the scope. And so there's little biopsy forceps that look like little alligator pinchers. And then there's also wire loops, like if you have a polyp, you can put the wire loop around it like a lasso, and then it's hooked to cautery, and as you squeeze the wire loop and tighten it, it burns through the polyp stalk, and it takes the whole thing off, and then we recover it to the suction apparatus. So anyway, this is what the scopes look like. And then, the doctor will go over the possible complications right before the procedure, before you give consent to do it. And so I might as well tell you what those are. Anytime we do any procedure on anyone, or even sewing up a cut, we're supposed to tell them about the possible complications or side effects. And so with colonoscopy, one of the problems you can have is problems with the sedation. And so if we got you too sleepy during the sedation, then we might have to breathe for you or give you drugs to reverse the drugs that we gave you. That's really rare to have that problem. It's been probably 10 years since I've had a patient who had a problem where we had to give them drugs. I've never had to breathe for anybody. But if you look over here, there's all this monitoring equipment. So there's an EKG machine, and then there's an anesthesia machine if we needed it. And then the anesthesia provider will be here, and then also the nurse. And so everybody will be monitoring you really close. But anyway, problems with sedation could be a possible complication. And then another problem that could happen would be bleeding. So if they find a polyp or or doing a biopsy and you biopsy some or take the polyp off, it could bleed. But we've got cautery with the scopes that we can make bleeding stop. But theoretically, even though in 25 years I've never seen it, it could bleed so bad and so fast that the guy doing the colonoscopy can't get it to stop with the cautery, and you'd have to call the surgeon to make it stop in the operating room, which is just right next door. But I've never seen that, but that's a possible complication. And then another one is perforation. So that's the one that everybody worries about. So that's popping a hole in your colon. So like I said before, without any stool in your colon's like a flat balloon, and you have to blow it up in order to see around in there. And so if there's a weakness in the bowel wall, the air that you put in there could pop a hole in your colon. Or if you're biopsying something or burning something, cauterizing something, then it could burn a hole through your colon. And so knock on wood, I've still never had a perforation in the 25 years, but across the country, a perforation will happen 1 out of every 2,000 times. And so if that were to happen, they say that the doctor often doesn't know that the perforation's there because the holes are so small you can't see them. But later that night or the next day, the patient would get abdominal pain. So we always tell people, if you get really bad abdominal pain tonight or tomorrow, then come back to the hospital. And what they would do is look with a CAT scan to see if there's air in your abdomen but outside your bowel. And if they find that, then likely you have a hole in your bowel somewhere, and that would require surgery to fix. So the risk of that across the country is 1 in 2,000 times. And I think in PAL we've had 3 or 4 since I've been here, maybe. And like, thankfully I've never had one still. But so they're pretty rare. It's generally a pretty safe procedure. But that's the complication everybody worries about. And then another thing I might mention is some people are worried that wondering about, does this hurt? And so the worst part of the whole experience for a colonoscopy is usually the bowel prep. So that's the night before, and we give you this stuff to drink that cleans your colon out so we can look around and see in there. And so you have diarrhea for about 3 hours, and it's pretty impressive diarrhea, but most people tolerate that just fine. And I didn't think it was that bad whenever I did mine. And then the question as to whether this hurts, well, you're going to be sedated, so most people don't remember anything from after getting in here until they wake up, and which is really pretty quick. You wake up quick with the medicine that the anesthesia guys use. But even if you were awake, you don't have any pain fibers in your colon, and so you can take biopsies of the inside of your colon, or use the lasso thing I was talking about to take a polyp off, and people can't feel that because you don't have any pain fibers in your colon. The thing that you feel is stretching of the colon, so like really bad gas. And so that's why we sedate people, because going around corners it can stretch your colon and make it hurt. But so really, basically, when you come, the only thing you're going to know is like you go to sleep and you wake up. So hopefully that answers a lot of your questions. After the colonoscopy's done, then we go back to those rooms where you had the pre-op, where they put the IV in, and then your family meets you in there, and then the doctor often comes in there and tells you what they saw or didn't see, because most of the time you don't remember while we're in here. And then, if they did a biopsy or something, then we send those to Billings to have the pathologist look at the biopsy or the polyp under the microscope, and then normally within a week we get you the results of that. So hopefully that makes you not as nervous about what a colonoscopy is all about. We talked about the other colon cancer screenings methods, and I think it's a good idea to get screened for colon cancer because it saves lives. Thanks for watching.